Good afternoon. Welcome everyone to join us for this lung cancer public awareness event. Also welcome to the people in the remote site joining us through the WebEx. My name is Zaolin Shu, a lung pathologist at QE2. I'm also the main lung pathology consultant in the region. In addition, I'm also a lung cancer researcher and one of the organizers for this event. Now, let me introduce to you Mr. Louis Brill, who is the President and the CEO, Lung Association Nova Scotia, who is also one of the organizers for this event. Welcome, Mr. Louis Brill.
We are excited to be here. I don't think ever in my life I've spoken about lung cancer more than in the last month or so. It seems like each day at our office we talk about lung cancer and lung cancer and then more lung cancer. And excitement grows when we talk about this subject. It's something that we've long talked about getting involved with and doing something positive about. What we quickly learned is that even at our lung association, lung cancer was something that we've talked about and heard about, but maybe something that we really truly didn't understand. And that we maybe had very limited knowledge when it comes to the reality of lung cancer in Nova Scotia today. Lung cancer is the leading cause of cancer deaths in Nova Scotia for both men and women. We know, it's been well documented, that the funding for research and support of folks impacted by lung cancer trails a lot of, or it seems like it trails a lot of other groups. And why is this? Why is this? This is a question that we intend to answer, and it's certainly something, if it's a reality, and we believe it's a reality, that must change. We must do something to help people who are impacted by lung cancer live a higher quality of life, and that's what we intend to do. We know that prevention certainly is a great opportunity regarding lung cancer. But the fact of the matter, when someone has lung cancer, we have to find ways to help them today. We have to find ways to help improve their quality of life. And also, I think, to help make our healthcare system more efficient, more effective. And our early studies again show that the research and the research and the support given to people impacted by lung cancer trails, and we certainly want to change that. At the Lung Association, we have set 3 priorities going forward, current priorities. One is spirometry testing. We want to make sure that that's an efficient reality in this province. 2, tobacco cessation. Make sure that what we do to help people who do smoke and want to quit effectively. So that's something we're looking at right now. And the 3rd is lung cancer. And I will tell you that we are bringing this subject to the table nationally, and we hope to engage our partners in every province to make lung cancer a priority issue with the Lung Association. That might sound like an odd thing. How can't it be? But like the Department of Health would say, there are so many issues involving lung health. You have to pick your priorities and your focus and really not hope to do something about it, but intend to do something about it, and we intend to do something about lung cancer in Nova Scotia. I love it to start here, and today is an exciting day. So where to start? Not long ago, with the advice of Dr. Bowie, I reached out to Dr. Mariski and Dr. Bethune in an email saying, we're interested in getting engaged in lung cancer. And not long after that, I was introduced to Dr. Zaolin Shu, who I soon after met and realized that we were not alone in our passion to do something about lung cancer. Dr. Shu, his passion is unwavering. Without him, this event today would not have happened. And although we didn't plan necessarily to host an event today, he did. And it was clear that it was an opportunity for our groups to come together to form a coalition and maybe some real momentum on lung cancer. So, Dr. Zhu, I want to thank you for your leadership, and we're honored to partner with you and all of your colleagues. So thank you very much, Dr. Zhu. I would have applauded for Dr. Zhu. In your agenda, you'll see there's we're going to talk about the current status of lung cancer in Nova Scotia, and you'll meet some of the leaders in that regard very soon. In the middle section, we're going to have a patient forum, and this is where we're going to break into some small groups. We'll have a facilitator and a recorder for each of those groups. We want to ask you a couple of questions. We want to explore how your cancer was diagnosed. Not how it's diagnosed, but how you were diagnosed. What was your experience? We want to talk about your experience once your lung cancer was diagnosed. We want to ask you a question on what are your challenges living with lung cancer? And then we're going to ask another question about the future and how perhaps you might be involved and advice you might give us. So I look forward to that. And I want to share you a story about a movement. When people talk about a movement, we're throwing the word movement around, and momentum. Momentum we already have. But when you talk about movement, it's scary because most movements are big. They're massive. And I had the privilege of being involved in a movement in a previous life in the sport world. And it was a sport organization many of you may have heard about. It's called Special Olympics. And I had the privilege of becoming good friends with the founder of that movement, Dr. Frank Hayden, who's a great Canadian, and the Shriver family from the States. Late night in a hotel, I asked Dr. Hayden, I said, well, how did it really start? This is incredible. There are people all over the world involved. And he said, you know, I was doing a research paper, and I believed that people didn't walk around overweight with their heads down, slumped shoulders, awkwardly because they were mentally retarded at that time. The words have changed. He said the reason they walked and looked and acted that way because they weren't engaged. They weren't fit. They weren't active. They didn't do sport like other kids do. And if they did sport and activity like other kids do, they would walk taller. They would get public respect. They would live longer, and they would be healthier, and they would have a better quality of life. He wrote this paper, and a woman down in the United States, her name is Eunice Shriver. She's recently passed away, John F. Kennedy's sister, influential family, heard about it and called Dr. Hayden and said, we'd like you to do that, and can you do it in the States? And Dr. Hayden said, no. They got together, and away they went. And they started a sport training program. Soon after, they had a competition. They did not have a name, Special Olympics. That was not conceived at the start. It was just, if we can get people to be healthier and active, things could be better for this group of people. And they started to test it, and they got more and more people engaged and involved. Well, I think that history will speak very kindly of the evolution of Special Olympics. We don't use retarded anymore. I used to have medical professionals call me and ask me what the proper terms were, what the Special Olympics use as their terms, and people with a mental challenge. People are healthier, people are active, people are core members of the community, and people who have a mental challenge are, and I would say it's part of that movement called Special Olympics has caused that. So it's important to remember that now there's millions of people involved in Russia, Lithuania, the United States, Canada, involved in that movement that did not start as Special Olympics. It started as a simple idea by a researcher in Ontario, hooked up with a person with influence in the United States, and the benefactor has been the world. The benefactor has been the world. And if anybody thinks the prostate cancer movement started with Movember in mind, they're wrong. It started with a group of people coming together, wanting to do something, seeing a need and saying, we're going to do something about it. We're going to do something about it. If anyone thinks breast cancer research, the run for the cure started when breast cancer movement started, they're wrong. It started as a small group of people, and ideas came when they listened and they learned and they got creative. So let's understand what we're trying to do here And maybe we'll look back someday in Nova Scotia and say, today was an important day. I believe it will be. And we start today. We don't need to go outside this room to motivate people and to engage people on lung cancer. And you're going to learn why I think that way in the coming presentations. So the engagement to date, we have healthcare professionals. We have some of the leading healthcare experts in this room right now, very engaged to take it the next level. And you're going to meet some of those people. We have Cancer Care Nova Scotia engaged. We have the Lung Association engaged. We have pharma industry engaged. And think the pharma industry, the pharma industry, not only can they bring funding, but they can also bring expertise and passion. So they work every day in fundraising, but they're people who want to make a difference. And I've met these people, and we have them engaged. So now we need to reach out. We need to reach out, and there's 3 groups that we've targeted right now. One is we need to target funders, because you need to sustain a movement, find some way to support it, and we're going to be going out and doing that in the near future. We also need to engage the provincial government, because if we want to, in the end, implement things within the healthcare system, a lot of it will come from the public purse. So it's important that we have the provincial government engaged right at the get-go. And we inform them, and they're at the table as partners. Everybody I've met within the Department of Health wants to make Nova Scotia healthier. How to do it is the question. And we need to be at the table with a loud, strong, smart voice, and that's what we're going to do. The third group is the patient and family group, the supporter group, the experts, in my opinion, of lung cancer. We have medical experts, we have structural and government experts, but when it comes to really understanding what the deal is with lung cancer, what the reality is at home, it's the patient and supporter group. We need your input. We need your involvement. We need your advice. We don't want to do things that aren't smart. And we don't have that knowledge yet, but we start today. So I'm very excited that you are here. Today is an exciting day for me personally and for our team at the Lung Association. I think we should get going. I think we start by bringing people together, by sharing our information, by listening and by learning, and then by absolutely intending to do something positive about lung cancer. And we definitely can. And if it starts in Nova Scotia and spreads across this country, well, that's a good thing for Nova Scotia. I would like to get the ball rolling right now, and I'm thrilled to invite Minister Len Prayad to say a few words. The Minister of Culture, Community and Heritage he has attended many Lung Association events. I don't know where he makes time and finds time to attend everything, but we're thrilled to have you here, Mr. Minister, and I welcome you to the stage. Restart later.
Okay. Well, good afternoon, everyone, and thank you very much for inviting me. Louis is a real force of nature. I've seen him over the years with so many great events, and not just with the Lung Association. He's so involved, and I think I first met you when you were involved with the Lung Run many years ago. But thank you very much for taking this initiative. I was saying to a group of physicians earlier on, most of my expertise is in the area of political mobilization and social mobilization. I'm a political scientist and a faculty member at St. Mary's, and it's how things happen when you can build a movement or a group of people who are concerned about a particular issue. Coming from diverse backgrounds, particularly now that I'm on the government side, I appreciate even more how important it is to have these large mobilizations of people who are practitioners, who are patients, who are supporters, who are caregivers and all that, because it means more. We can draw a lot more from the conclusions reached by that movement. And of course, from a political point of view, the large numbers mean something at the ballot box as well. But that's not the important part. The important part is that you get more legitimacy and you get more influence by the experts and the expertise and the talents you bring around the table. So I'm delighted to be here to see the continuation of this movement and the people who are going to help make it grow. As you gather from my ministerial title, I'm not the Minister of Health. I'm filling in for Minister Wilson, who couldn't be here today but asked me to say a few words on his behalf. I'm delighted to do so, and like probably everyone in this room, we've been touched by cancer, and in fact, that's probably one of the few good things you can say about it, is that it makes all of us kin. We're all relatives to the fact that we have or know someone who has been involved with it. I myself had a 2.5 terrifying moments of 2.5 hours of moments of living with lung cancer. I had trouble breathing about 6 years ago, and had a battery of tests, and eventually said we got to do some X-rays, and noticed some lumps on my lungs, and my doctor called me in and said, you've got lymphoma. I didn't know what it meant. I did a lot of work, and promptly went home and did my income tax. I hadn't done my income tax in about 3 years. And then I got a call from the hospital about 2.5 hours later, and said, the doctor wants to talk to you again. And it turned out I had something called sarcoidosis that he said presents in much the same way. And he said, this is great news, but it was for me, it was a very brief little window on the kind of terror and sort of anxiety you can personally encounter with a diagnosis. And some of that is, is based on stereotypes about living with cancer, and but it still strikes a terror, and it certainly from a government point of view, it made me appreciate even more the impact that cancer can have on individuals and their families. We know that cancer is that more than half of the deaths in our province can be attributed to cancer, and that lung cancer alone kills more men and women than breast and prostate cancer combined. So it is a very important disease in that. So it's important to know what we have to do with it in terms of treatment and diagnosis and prevention. And I'm delighted that this coalition has taken this challenge on. As an academic, I know how important conferences like this are, where you can network, and we can build these networks of collaboration and understanding in particular fields, to share knowledge and approaches and advances in diagnosis and treatment. And that's how advances are made. That's how we deal with some of the biggest issues. And as I know, as the member of the legislature for Halifax Citadel Sable Island, which is the downtown Halifax, I know that a great work is happening in this province and in this area by Cancer Care Nova Scotia, a number of researchers working at the hospitals, a number of researchers working at the universities. I know the Department of Health and Wellness funds a great deal of the research. There's work done at the Tissue Bank by organizing the Lung Cancer Symposia, for example. A whole variety of ways of making sure that we take advantage of these networks and the great resources that we have here. But we know that research is important, but so is timely access to cancer care. Early diagnosis and treatment is an important part of it. And just last week, we announced the expansion of the Nova Scotia Cancer Centre by unveiling the new James and Edna Clayton Radiation Treatment Clinic, for example. And the clinic is a significant addition to support for Nova Scotians living with cancer. 6,000 more will be diagnosed with cancer by the end of 2012. And the expansion of the centre and the addition of the radiation clinic mean that 200 more Nova Scotians are able to receive treatment within the first 8 weeks of their cancer diagnosis, the most crucial time in the treatment of this disease. In other words, right now, 100% of all Nova Scotian patients get radiation therapy within the 8-week wait time guarantee. And better yet, our most recent information tells us that 83% of our province's patients receive therapy within the 4-week clinical benchmark, and this is a national standard. And as you know, it is a very important issue, this question of wait times guarantees and what kinds of guarantees we can give. It's part of the larger better care sooner. It's not just a slogan. Better care involves timely diagnosis and treatment and reduced wait times, both for patients and caregivers and doctors. This is an important priority. Research is important, treatment is important, but we also have to be sensitive to the needs of patients. As someone who has had my late wife and mother both died after very long battles with cancer, I know how important it is to have to pay attention to the needs of the patients and their caregivers. The question of home support, for example, the government is committed to providing home support and palliative care through the continuing care branch of the Department of Health. And for the purpose of this conference, it's important that we learn from patients and caregivers in terms of what we can do to provide better care in the home, closer to home, or in ways that are appropriate for patients and families. And of course, we also know that the best way to treat cancer, any kind of cancer, is through prevention. And provincial initiatives like Thrive are aimed at that and focusing on getting Nova Scotians out of all ages to eat better, to move more, to be physically fit. And the benefits will be not just in the treatment of cancer, but also in a number of chronic diseases. And Lewis has also already mentioned about reducing smoking rates. And we have seen extraordinary progress in some areas. I think we've seen more in men, but unfortunately, we're now starting to see the front end of the great women's liberation movement that said you have the right to pollute your lungs. But we are seeing a huge change in the culture around that. We do need to work together on all of that, on research, on treatment, on home care, on prevention. And I'm delighted that this conference and the partners in this conference are aimed at addressing different aspects of this issue. As a government that is committed to doing things on an evidence-based research, on evidence-based work done with patients and clinicians and caregivers, it's really important for us to know what the findings of this conference will be, because it will help us lay down the foundations for better healthcare policy, to use our funding more effectively, to end up with a more responsive treatment mechanism for patients and doctors and families and in the public good in general. So I'm really happy that you're getting together here and plan on being active and building this network. I want to thank the Lung Association, Dr. Zhu, Cancer Care Nova Scotia. I know there are a number of other partners in this room, but in particular I want to thank the patients and the caregivers for coming out. And on behalf of the Minister of Health and the Government of Nova Scotia, I'm very much looking forward to seeing what results you come up with and how we can learn from your experience today and going into the future. Thank you. I'm sorry I took my out.
Thank you very much, Mr. Minister, and thank you for joining us here today. Hearing the initiatives of the government is very enlightening. We appreciate the efforts that are being made currently. And you mentioned foundation, and that's kind of what we're looking at building here in future partnerships. We pledge to keep the government informed and to certainly welcome partnerships as we go through each step of this, I guess, the development of what we hope becomes a movement even larger than we have today in the future. So again, thank you very much for attending. I appreciate it. Now we're going to get on with our agenda. Our first speaker, Dr. Drew Bethune, he's the chair of the Cancer Care Program. He's the chief of that program. He's a thoracic surgeon at Capital Health, and it's a pleasure to welcome Dr. Bethune to the stage. Please.
For being the driving force behind making this happen. And I also want to recognize that the object of this is to develop a dialogue between those of us who treat lung cancer and to get some return dialogue from patients. The management of lung cancer is very complicated. There is a complicated system to deliver cancer care, and there are parts in that step in all the steps involved that don't always work perfectly. So having a dialogue back and forth, I think, is really important. We recognize that lung cancer does not have the same profile as other cancers do, and we wonder why. It is the most serious cancer and is responsible for the largest number of cancer deaths. Cancer recently overtook cardiovascular disease as the major cause of deaths of Canadians, and lung cancer is the major cause of cancer deaths. Let's just look at the Canadian cancer statistics from this year. This is the most recent publication of true real-life statistics in Canada. And what we have here are the new cases of cancer and the deaths from cancer. And as Minister Pereira said, lung cancer causes more deaths than the next two, colorectal and prostate cancer, combined. It is a very large cause of mortality in men, and the same thing in women. It causes more deaths from cancer than breast cancer and colon cancer, the next two, number 2 and number 3 in women. Breast cancer is more common, but as a cause of death, lung cancer is by far the major mortality cause. We find that as the population ages, the risk for cancer increases. So we will be seeing an increased burden of cancer and of lung cancer in years to come. When I started thoracic surgery, there were slightly under 700 cases of lung cancer a year. This year, there are projected to be 930 cases of lung cancer per year. Nova Scotia has the highest rate of cancer in Canada. More or less, the highest rate of lung cancer is shared between us and Newfoundland, PEI, and Quebec. It's variable which one is the first. When we look at cancer overall, there are 6 areas. I've put number 5, 2 areas. But there are 5 basic areas where we want to look at cancer control. There's prevention, there's screening. Certainly for breast cancer, mammography is an example of that. Colorectal cancer screening is an example of that. There's diagnosis, there's treatment, and survivorship and palliation. And in all of these areas, there are exciting new things happening in lung cancer. It is not a static area. There are quite remarkable things happening in many, many areas in lung cancer, and I'd like to share those with you today. Now, we think of lung cancer as being a lifestyle-related disease due to smoking, and I wonder if that's why lung cancer doesn't have a higher priority. Certainly, lung cancers are caused, the majority are caused by smoking. So does that mean it shouldn't be supported in any way? Let's look at some other lifestyle-associated diseases. Colon cancer, for instance. 50% of colon cancer. I was at a meeting on Thursday. This is right off a very recent meeting looking at colon cancer. 50% of colon cancer is due to lifestyle, diet, obesity, inactivity. American Institute for Cancer Research. Heart disease. Actually, more people die from heart disease from smoking than from lung cancer from smoking. And we certainly have very active advocacy groups for heart disease, and we have very good funding for heart disease. Good funding for research in heart disease. Breast cancer. Obesity, alcohol, physical activity play a major role in breast cancer. What about diabetes? There's a lot of funding, a lot of research, a lot of public interest in diabetes. Well, a lot of diabetes is related to obesity. Kidney failure and heart disease are secondary to obesity-induced diabetes. Knee replacements related to lifestyle. AIDS related to lifestyle. So I think we have to really wonder why there is not more attention placed on lung cancer, because it is due to lifestyle, but all of these other cancers are due to lifestyle also. All of these other diseases. Where have we progressed with relation to these 5 different areas of cancer control in lung cancer? I would like to say that with the support of the Lung Association years ago, we have made huge progress in tobacco control. When I was in medical school in the 70s, we had ashtrays for all the medical students to smoke. All of the lung specialists, when I was a medical student in the 70s, all of the lung specialists smoked. So we had a tobacco culture. 60% of males smoked in the 70s. The latent period for tobacco-induced cancer is 20 or 30 years. So the rate of smoking in males has gone down considerably, and now, finally, slowly, the rate of cancer is reducing. 50% of patients operated on for lung cancer are non-smokers. They might have been former smokers or never smoked before in their lives. So we really have to look at tobacco as being it's being an element, but it's not an active element. And I think when we look at advocacy and we look at developing movements, that certainly this is not an impediment for us to develop a strong voice publicly in advocating for people with lung cancer and the care and programs for lung cancer. The provincial government has done what they needed to do in enacting laws to prevent youth from getting easy access to tobacco, which is highly addictive, probably in the same realm as cocaine or heroin. There have been public places legislation, tobacco cessation programs, and there's been research in non-tobacco nicotine products and drugs that target nicotine receptors in the brain to help reduce tobacco addiction. What about screening? I'm not going to say a whole lot about screening. Dr. Michael Johnston will be talking about that later on. We are, in Canada, leaders in designing research for the evidence-based demonstration that with new technology, new CAT scanners, where we can scan people very quickly, we are able to pick up lung cancer at very early stages, and in the early stages, lung cancer has a very high cure rate. So this is probably profoundly one of the areas of research that will affect our overall cure rates in lung cancer more than anything else. A very, very important initiative. Here's an example of a lung cancer, and the white area is the cancer, and that's a cancer that the patient would not feel. It's completely asymptomatic. It was picked up by screening, and that patient would have about a 70% cure rate with surgery and no other treatment for the cancer. So that's an example of how screening can be extremely beneficial. What about the diagnosis of lung cancer? Is there anything new in the diagnosis? And yes, there is. The technological advances with CAT scanning have enabled faster scans to be done with a lower dose. It's made it practical to follow lung cancers in some situations, patients who have had surgery, to have screening after the surgery for occurrence of a new lung cancer. And it also has made the possibility of screening the population at risk at large for lung cancers. PET scanning is a new type of technology that we've had for now about 3 or 4 years, I believe. And it's a remarkable technology where actually you can inject a radioactive tracer and it will actually show the cancer. It's been very helpful in staging cancer. So here's an example of a positive PET scan for a lung cancer. This is the patient's body, and that black spot is the radioactivity being taken up by the cancer. We often find little spots in the lung when we do CAT scans, and we don't know if they're cancer or not, but the PET scan can help us determine if it's cancer, and it can also help us determine if the cancer spread anywhere. So this next PET scan shows a cancer here, and it's spread to 2 lymph nodes. So it actually gives us extremely useful information. It's marvelous technology, and we use it frequently now in dealing with lung cancer. This is an unfortunate patient with widespread cancer that the PET scan has shown. It's spread to other places. We're at the threshold of personalized medicine. Molecular medicine now is going into the clinical arena. We are now able to look at cancers not only under the microscope, but actually to get the genetic footprint of cancers. And why is this important? There are marvelous new drugs now that can target the abnormal area in a cancer cell and actually have very minimal side effects and just treat the cancer. One of the problems is trying to find these patients because they require sophisticated testing to find this mutation. And there are now, instead of treating everybody with non-small cell lung cancer the same, we are finding that by their molecular profile that there are different groups of patients that respond to different kinds of treatment. We actually have found in lung cancer, more so than almost any other cancer, that there are more of these mutations. 50% of lung cancers have these mutations, and Dr. Morzicki is going to be speaking about this in more detail later. But these mutations, some of them can be treated by specific drugs, which have changed the whole picture of lung cancer treatment. This is an example of one of these surface receptors, and when it gets mutated, a switch turns on, and it ends up causing the cell to reproduce and divide faster and faster and faster and to spread to other places. So in turning off this area right here by a drug, we can put the brakes on the cancer and stop it in its tracks. So this new type of personalized molecular medicine, it's here now, and it's miraculous. Doing this in the lab is complicated. We have to do a special kind of analysis, molecular genetics analysis. Here's a picture of a mutation that we're actually looking at the cells and analyzing those dots, and when the dots show a certain pattern, the patient has the mutation. In Nova Scotia, we're the first place in Canada to be able to do this, and I want to point out that the group here of cancer doctors and technicians and the whole team, we're doing things that are the best in Canada, and I emphasize that we don't have to feel second-rate in Eastern Canada. We're as good as anywhere in the country, and we're doing things that are cutting edge. And this is a kind of a diagnostic modality that should be available for all lung cancer patients. In cancer centers in the U.S. it's available, in Europe it's available, and we are doing it here in Halifax. And it's due to the efforts of many people, Dr. Zhu among them, who's driven this initiative. When we look at treatment, I'm a surgeon, and I am interested in doing surgery, and I'm going to show you a few pictures of some of the new evolutions in surgery. Two objectives in surgery: control of the tumor locally, but one of the problems with cancer is it can spread to other places. So also part of the treatment is to try to prevent it from spreading to other places. There are many different treatment options: surgery, radiotherapy, where you shine an X-ray beam at the tumor, chemotherapy, where you give drugs, and targeted molecular therapy, which is what I was referring to just a few minutes ago, targeting these mutations. So surgery, we do two things in surgery. We obtain the diagnosis, and we also do treatment. And those aren't the same things. Sometimes patients have an advanced cancer, and the best treatment is not surgery for cure, but giving chemotherapy, radiotherapy, and other times we do surgery, not only to get the diagnosis, but to do treatment. So we have 3 lobes in the right lung, 2 on the left. Just show you a few pictures. There's the bronchial tubes. There are the pulmonary arteries, and there are the pulmonary veins. So the new technology for surgery is minimally invasive surgery, and in about half of lung cancers, we're able to treat patients without opening up the chest. It's quite amazing, actually, and it's related to new technologies, good cameras. We put a telescope in there so we can see what's inside, and instead of making a big incision, which can cause a lot of pain and disability for quite some time, we're able to do it through small incisions without opening the patient's chest. This is the view we have. This actually isn't lung cancer, but this is what it looks like inside. And we do this all at a distance, and we put these devices in here and staplers, and we staple off the vessels, and we're able to take out the lung cancer. And this is what a lung cancer looks like. This is actually normal lung, and this is the hard growth of a large lung cancer. So that's surgery, and we do that in selected cases. Not every case is a candidate for surgery. Radiotherapy is also another technique, and to echo Minister Pereira's comments, we have state-of-the-art equipment. We have the best equipment in the world, and it just happened by happenstance that we required new radiotherapy equipment, and it just came when the new technology became available, and the machines we have are marvelous. We have the best radiotherapy equipment in Canada, period. Nobody would doubt that. We are in the top 1% to 2% in North America with our equipment. And what does that mean, having good radiotherapy equipment? It's highly technological. It's like a missile guidance system with very powerful radiotherapy beams directed extremely accurately at the area of tumor. And what we're always trying to achieve with radiotherapy is to target the tumor and not to target anything else. So with these new machines, which are run by computers, and we have, I think, 8 PhD medical physicists who run these machines and calibrate them, and a whole team of experts, we are able to harness the potential of these new machines, which are absolutely incredible. The radiotherapy treatments will be faster, more accurate, and we will be able to serve the population even faster than we are now, because we'll be increasing our capacity from 5 to 7 machines. This is what the machine looks like, and it's the state-of-the-art system, and this is the machine that delivers radiotherapy, and it moves, and the table moves, so everything moves, so you can target the beam right at the tumor. Here's an example of a computer model on a real-life CAT scan of where they're targeting the tumor, and they're able to very accurately target the tumor. And certainly lung cancer is a tricky one because you have to breathe. You can't hold your breath all the time. But they've actually got devices that they have a CAT scan through the aiming port where they actually can move the radiotherapy beam with breathing, or they can gate it, and they can do it only at the end of your breath. So it's remarkable technology, highly sophisticated, and we really, the average person doesn't understand all that goes on behind the scenes to deliver state-of-the-art cancer care. When we look at treatment is done in a multidisciplinary team. About 15 of us meet every Wednesday and have for at least 10 years. Experts in surgery, chemotherapy, radiotherapy, radiology, x-rays, pathology, and this team has been the cohesive nucleus that has helped us go forward in many different areas. For instance, our molecular treatment, establishment of a molecular lab with partners from the pharmacy industry and the National Research Council. It's enabled us to expand our options. But also, cancer care is so complicated now that no one doctor can know everything. We have to have a meeting of experts, and modern cancer care requires the ability for different specialists to meet together. This is one areas that I think has contributed to a great extent in our ability to deliver quality integrated cancer care. So cancer treatment's not just surgery, not just radiotherapy, not just chemotherapy, not just targeted therapy. It's a combination of those different treatments depending on the different situation. It's personalized care, it's individualized care, it's different for everybody. Depends on your age, depends on the stage, depends on the kind of treatment, kind of cancer that you have. When we evaluate a patient, there is a bifurcation in the highway, and it's cure versus palliation. When we do curative approaches, we expose patients to toxic treatments in the hope of eliminating the cancer entirely. Palliation is no less important. It's designed at using all of our technology to relieve the symptoms of the cancer, realizing that the cancer may not be curable, but we can certainly prolong the patient's quality of life and length of life with palliative approaches. So that was a quick run-through, and I could talk here for quite a long time about every little point along the path. But in conclusion, there have been profound changes in our understanding of lung cancer, and part of it's related to the Human Genome Project. In 2002, they decoded the human genome, and now we're able to look at cancers from this spectrum. Technology has advanced tremendously and is having impacts in every step along the way, in every way we treat cancer, from surgery to radiotherapy to chemotherapy to combinations of all of them. There are new approaches, as I've illustrated, in all areas of cancer control, and it is exciting. There is a chance that we are going to really have an impact on this devastating cancer. I feel inadequate attention is given to lung cancer. This is the major cancer problem by a factor of 2. This should be front and center in every agenda for cancer control. This is the most important cancer by far, and there are things, as I've demonstrated today, that can be done about it. There are more new discoveries on the horizon. So I'd like to thank you for having had this chance to talk to you about something that I'm quite passionate about. Wojtek Morsicki will be following me to talk about more about treatment of cancer. Wojtek's been a member of our group for at least 10 years, it would seem, and has been a great colleague in working together. Wojtek's an expert in medical oncology, the medical oncology of lung cancer, and has had experience in clinical trials of targeted therapy, and we're very happy to have him here today to talk about lung cancer.
Thank you. So my name is Wojtek Morsicki. I'm one of the medical oncologists, thoracic oncologist. I go by many names. So I got this name tag from Tara, George Clooney. So that would boost the ego of any man. I introduce myself to the patients, and it's not a joke. I'm telling them that among all those good people, thoracic surgeons and radiation oncologists, I have the worst reputation because I'm going to make them sick. So some patients remember my name as Morsicki. Some more whiskey, so many names. It's good to be here. I see a lot of good friends. Dr. Bowie, who was introducing me many years ago to respiratory medicine, great teacher who retired recently. Good to see you, Dennis. But I also remember meeting Drew Bethune. I was a rotating intern I'm not going to tell you when, it was a long time ago. And that was the first time when I learned about lung cancer. And then many other people. Nova Scotia makes huge contribution into the treatment of lung cancer. Charlie Batts, who is from Glace Bay, he's one of the most prominent oncologists in the country. He's now in Edmonton. I see a lot of patients of mine. Linda, who has been cancer-free for 6 years. Some patients, Navenka, hello. Tongjun, Linda, good to see you. So my presentation is going to be very brief. I have a few slides, and I'm going to talk more than show. So some of those slides will be repetitive, just because Drew already touched this in this subjects in his presentation. But what I'm going to tell you is that, just like Drew said, this is the team approach. I can't function without Drew, who is a thoracic surgeon, and his colleagues, or Javelin and his colleagues who are pathologists. There's absolutely no way that I can treat the patient without knowing if that's a cancer, what is the type of cancer. I can't function without the nursing staff, supporting staff. So this is a team. Radiation oncologists, of course, I can't forget about them. The key step, and you can see this big lump here in the lung, is the diagnosis. And with diagnosis comes the staging. The staging is a term we use to describe the whole process in which we're trying to determine how advanced the cancer is. Is it just localized, something we can cure, or it's something metastatic? So it's a completely different approach between those two. This is divided highway. You can cure or you cannot, but you can improve the quality of life and prolong life. Some patients, just like you saw in the previous slide, will have just local disease, and that's great, but that's a small proportion of patients. Unfortunately, 60% of patients would have this very diffuse metastatic disease, stage 4. We can't cure those patients. They can do well. And there's still a small percentage can live maybe even 5 years, small percentage. I have my own definition of incurability. The patients ask me, what do you mean you can't cure my cancer? I said, well, because I don't know what is your chance to be alive 5 years. But I do have patients who actually live 5 years and longer with the metastatic disease. Small proportion, but they do. So in the process, early process, before they actually are in my clinic, we would like to know what type of cancer it is. And first of all, is that a cancer? Sometimes radiologically, and Minister Pereira mentioned his terrifying moments, and he was told that, I think you have a cancer, but actually it was the sarcoidosis, I'm sorry. So you know, you have to be sure that this is a cancer. And my life has changed dramatically since Xiaolin joined our team. He's a brilliant lung oncologist, pathologist, and with his expertise, my life is easy. I know that I'm dealing with the lung cancer, and I know that I can treat it. So then we would like to know if the patient actually is suitable for treatment. Doesn't matter, radiation or chemotherapy. Is the patient well enough? Some patients are old. It's a difference between treating someone who is 45, and the youngest patient I ever had was 21, than someone who is 81. Two completely different situations. There could be different goals for those patients, and usually there are. And of course, we would like to know through the staging process, is it something, again, can be operated and cure, is high, or someone who presents with the stage 4 disease, which unfortunately is the majority of patients, and we would just provide palliation. And another aspect is what the patient wishes. Again, different group of patients. Someone who is 45 would do absolutely everything. He wants to go aggressive. But 81-year-old patient may have a bit different goals. This patient may just want to feel better or feel good without going through the horrendous sometimes experience with the chemotherapy. So very briefly, I'm not going to teach oncology, but for those, particularly my patients, you know, there's a small cell lung cancer. That's 15-20% of all cancers. We call it systemic cancer because when the patients are diagnosed, 99% of them have diffuse metastases in the bone, in the brain, the liver, everywhere. And it's one of those probably the most aggressive solid tumor we're dealing with. And there's a non-small cell lung cancer, which is 80-85% of patients. That's what the majority of patients are coming with to our cancer center. Two different biology, two different cancers, and two different treatment. And sort of, I shouldn't say early stage, but limited stage, we can still cure 20% of those patients. But majority would unfortunately not survive very long, just because it is a very aggressive tumor. Non-small cell has a different biology, and the pattern of this cancer is changing dramatically. I participated in a conference where one of the most famous epidemiologists, Dr. Pito, has presented quite staggering numbers. We do see now up to 25% of all the referrals in the world are actually lifelong non-smokers. Completely different, again, we believe this is a different type of cancer. It's a lung cancer, but it has a different biology. It's frequently loaded with different mutations, and Drew mentioned we can now analyze those mutations and target them with a very specific, almost stealth-like treatment. And the industry is providing, new drugs all the time. And we are first in Canada to have the molecular pathology lab which can analyze those cancers. We're first in this country. And we're already seeing this snowball effect. Other provinces want to do the same. We're operating for Atlantic Canada, so not just Nova Scotia, but it's been in existence in the States and Europe as a national programs for quite some time, and we just decided to do it on our own with the help of the industry. So the patient comes to the clinic, and we have information the patient has the cancer. We're looking for different things. One of them is the not just patient's age, but also the patient's history. Some patients have no significant medical history, but some patients do. I would say majority of patients do have some history, just because they're old. Again, one of the Drew's slides, majority of patients with any cancer, particularly lung cancer, they're old, 65 and older. We rarely see young patients. So we would like to know if they have diabetes, heart disease, because this kind of information can influence our decision about treatment. So the nurses and our assistants are helping us to, assess the patient's fitness for treatment. Simple things, vitals, blood pressure, weight. This all is the preparation for the making decision. We know that tiredness, fatigue, or weight loss are important factors to help us to determine who actually will or will not tolerate the treatment. We use the scale called performance status. Every oncologist does it. It used to be Karnofsky, which was very complex, complicated, but has been sort of replaced by ECOG, another sort of scale. Very quick, simple, helps me to look at the patient and say, well, I can treat you aggressively. First of all, I can treat you. Or I have to be very careful with your treatment, so I have to offer you something very light, or reduce the dose, or postpone the chemotherapy, things like that. Some patients, just because of that, cannot be treated. They would be unwell. Tons of clinical data supporting that patients who do have poor performance status, they don't complete the chemo, they have horrible time, and they don't benefit. And some would die. So we are always using those scales. This is again staging of lung cancer, something we do from the beginning, and with the help of all my colleagues, thoracic oncologists, and some respirologists are also involved in the investigating lung cancer. Patients is already staged when they actually see me in the clinic. So that helps to determine what form of the treatment patients will eventually have. First two stages are operable and highly curative. Stage 3, it's what we call locally advanced. It still can be cured. 25, maybe 30% of patients can be cured with concurrent chemoradiation therapy. Stage 4 is unfortunately majority of cases. The patients cannot be cured. So we provide benefit by giving palliative chemotherapy. We would like to support them by a variety of different ways, but we would like to also palliate these symptoms and prolong their lives. That's more for Drew, and he already mentioned this is, again, the same slide, X-ray. This is the tumor sitting here on the right side of the lung, and the surgeons would operate, either doing extensive surgery, but there's some new technology, sort of less invasive. Patients stay shorter. There's no comorbidities associated with that. But some patients are old. They still present with the lung cancer, but they cannot be operated for a variety of reasons. And then radiation oncologists would offer some form of the stereotactic radiation. It could be also provide some palliation of the, or even good tumor control. 60% of patients have this, again, diffuse metastases, those nodules you can see everywhere, that represent more diffuse disease. And this is what we see. We don't know if there are no microscopic metastases elsewhere. They likely are. So those patients, if they are suitable, will be considered for palliative chemotherapy. I'm not a radiation oncologist, but I think radiation oncologists are very smart people because they know cancer, plus they know the physics and mathematics and computers. They know everything. So they would target the tumor with the different beams of radiation from different angle, and the technology is amazing. And again, we have no doubt the best radiation oncology center in Canada. This is just a slide to tell you the purpose of the chemotherapy. Sometimes I have to explain to the patient, and that's the most difficult part of my practice, is to see the patients who I would like to treat, but I can't because they're too unwell. That is the heartbreaking experience, particularly if someone is young, comes in, poor performance status. I can't treat them. That's why I'm so excited, and so is the Xiaolin and Drew. 3 of us are behind 8 months of hard work and opening the molecular, we call it Atlantic Canada Molecular Oncology Center. First in such institution or such center in Canada where we can, by the reflex test, we can actually digest those tumors, look for specific mutations, and if they're there, we can target them with actually drugs which can be given to those sick patients, because most of them are oral, they're by taken as a pill. They have a very good toxicity profile, well tolerated. So even the patients who are truly unwell and normally cannot be treated can be treated with those drugs. Okay, so opening this program is by far the most important event in the recent history of this cancer center. And that's my last slide. Thank you very much for coming. I hope I didn't repeat what you heard from Dr. Bethune. And I'm really appreciate that everybody's here. I hope our audience next year will be bigger than it is today. Thank you.
Recent advances in lung cancer research mean that you and your doctor have new tools to help decide which treatments are most appropriate for you. When you were told you had lung cancer, you probably had many questions, such as, what steps should I take for you? When you were told you had lung cancer, you probably had many questions, such as, what steps should I take next? Until recently, doctors had only 3 options for treating lung cancer: surgery, radiation therapy, and chemotherapy. Today, some patients are eligible for new kinds of treatments known as targeted therapies, which attack specific targets on or within tumor cells that affect tumor growth. In order to know if you are a candidate for specific targeted therapies, your doctor may order a special test of your tumor called a molecular test. To understand the role and importance of molecular testing, let's start with some basics about lung cancer first. Your tumor started because of specific changes to some cells within your lungs that cause those cells to lose control over how they grow and divide. Each cell in our body contains genetic material, or molecules known as DNA, which contain instructions for making all the proteins our cells need. Proteins control many of the cell's functions. Sometimes DNA can undergo changes that result in permanent damage. These changes are called genetic mutations or alterations, and they can affect the proteins that are responsible for normal cell growth and division. The genetic mutations in lung cancer are only present in the tumor and are not thought to be inherited or passed from one generation to the next. Different tumors can be affected by different changes. It's important to know which changes your tumor has, because some of these changes may be linked to how you will respond to therapy. To find out what genetic changes are present in your tumor, a special doctor called a pathologist must conduct a molecular test of your tumor. What is molecular testing? When you were diagnosed with lung cancer, a sample of your tumor had to be examined to learn where in the body it started and what type of cancer it is. Today, doctors can perform additional testing. This testing is referred to as molecular testing. Your doctor may also call these tests biomarker testing or mutation testing. All of these terms refer to tests that look for changes in the tumor. Currently, molecular testing can identify changes in the DNA makeup of the tumor or measure levels of specific proteins present in the tumor. In any tumor, many different changes are possible, and not every person's tumor will have the same changes. Why is molecular testing important? It's important to identify whether or not your lung cancer has specific changes, because this knowledge can help you and your doctor come up with an individual treatment plan that is right for you. How does molecular testing work? Molecular testing starts with your doctor taking a sample or biopsy of your tumor. If molecular testing wasn't done on the initial biopsy that determined your type of cancer, your doctor can ask to have the tissue re-examined, or a second biopsy may be needed. These tests will show whether or not your tumor has any currently known changes. Test results are usually ready within 1 to 3 weeks after the biopsy. What will the results of molecular testing mean for your treatment? Based on results of molecular testing on your tumor, your doctor will develop specific treatment recommendations for you. If available therapies are not an option based on your results, you may qualify for a clinical trial testing treatments targeting the specific changes within your tumor. To find a clinical trial, speak with your doctor or go to clinicaltrials.gov. Even if your tumor does not have known characteristics that can be matched to a targeted therapy, molecular testing can still help you and your doctor decide on the most appropriate treatment for your cancer. Knowledge is power. Power to make informed decisions about your care. Talk with your doctor to see if molecular tumor testing is right for you. If your doctor doesn't recommend molecular testing and you still have questions, consider getting a second opinion. To learn more about lung cancer and molecular testing, go to these websites.